Hello, it's John Canalopoulos from Center here in Athens, Greece, the LaserVision Ambulatory Surgery Center, Clinical Professor of Ophthalmology at NYU Medical School, New York City, New York. We're going to see a very rare complication. I don't think I've ever seen one like this, a cornea perforation. So this young 34-year-old lady last week, we can see here from a treating physician, her 3-year follow-up, and there's really no cornea change if you look at the OCT pachymetry maps. For some reason, the cornea curvature may have changed, and the surgeon panicked, offered CXL combined with a surface ablation. I'm not sure what the protocol was. 1 month later, this lady has a complete cornea perforation with an iris tag. Uh, Fortunately, no choroidals here seen from the hypotony, but excruciating pain as her iris was hanging out from this cornea perf. Apparently, the steroids were continued almost on a 2-hour basis for a long period of time, and keratolysis probably took place. This is the Moria Busin donor tree find. Thanks for my friend Massimo Busin for designing this. And this is really tough. We're going to go with a Baron tree find, and the donor was 8.5. We're going 7.75 here. It's very difficult to tree find a soft eye, very large defect to glue. So I'm going to create a opening with the Baron host tree find, and then try and find my marks with the Castro Viejo left and right scissors. It's always key here to go in and then bring the scissors vertically. And of course, the video is running 8 times speed. The toughest part was here to finding the host cornea. Some portions were easy, some were difficult because of significant cornea edema. Fortunately, there's not significant damage to the lens, although the eye was perforated for almost a week. For some reason, the treating surgeon was hoping that this would heal on its own. So we don't have good borders here. I'm going to go in and sharpen my borders. I want them vertical. And again, repeating, we're 7.75 on the host, and we just refined 8.5 on the donor. Again, thanks to CorneaGen for allowing this tissue to come all the way out from Seattle to Athens, Greece. Very timely, very excellent care in a team that works very well. Our 6 o'clock, again, this is our large graft. We're slightly in the limbus. But it's a beautiful graft. It's 7 days old. We can see it's crystal clear. Death to preservation was 12 hours. And I've inverted the image to depict the 12 o'clock position of the patient at the 12 o'clock that we're seeing. So obviously this is not the surgeon's view. This is upside down. Suture 4, and so on and so forth. But I wanted to take the opportunity while we're watching standard cornea transplantation. The only difference here is that in keratoconus, we usually oversize the graft. I usually oversize the graft 0.25 millimeters. Here, because I tree find on a soft eye and the cornea was very flat, I decided to oversize by 0.75 millimeters, as mentioned before. It's very important for the new people in this art of penetrating keratoplasty that all knots should be square. I'm of the Dolman school of going very deep, but just flush on decimates, as you can see here, both on the donor and now on the host. Want to have good visualization, just flush over decimates, suture deep, quite large sutures to have very good opposition. Again, square knots, trim short so they can bury. So I was saying before, this is a very difficult puzzle on why this young lady with no underlying medical conditions, she actually was scheduled to start working in Finland the day that we saw her, unfortunately, with this devastating complication. One of the interesting things is that she had excruciating pain since the cornea perforated because an iris tag got trapped in the opening of the cornea, and obviously resulting in very significant pain. She couldn't sleep for several days. We tried to glue it, but the defect was quite large. Plus, she was in a lot of pain, and it was almost impossible to, in the office, administer bulb anesthesia with a soft open eye. So our classic 8 interrupted sutures. As we do not know the cause of the melt, She's already on 40 milligrams of tetracycline daily in the form of Oracea, the formulation that gets absorbed deep in the GI tract, so not to upset the gastric mucosa. And I'm speculating that there was probably a persistent epithelial defect. The steroids were not tapered. I would have stopped the steroids for several days until the epithelium has healed. And obviously, she received no antiproteolytic treatment such as tetracycline derivative, doxycycline or minocycline. In this type of melt, I usually ask very carefully if there's any topical anesthetic abuse. Obviously, in my term, in the inner neighborhoods of New York City, we often see crack users have inadvertent corneal perforations from the cocaine vaporizing the surface of the eye, rubbing the eye, getting a defect, and then continuously use cocaine to alleviate the pain of the defect. And I've seen it several times with topical anesthetic abuse. But usually that results in significant conjunctival disease, almost a complete conjunctival toxicity. The anesthetic finds itself in the anterior chamber. Usually there's iris ectropio and significant glaucoma associated with that. Here we can see the anterior chamber is quite quiet. We're very scared with the perforation because she was on no antibiotic prophylaxis. So I want to mention here that this patient received 3 days of fortified antibiotics, both vancomycin and cefazolin, in order to eradicate the risk of possibly having a significant cornea, anterior chamber, maybe endophthalmitis infection. We took cultures as well, which have not come back yet. It has not been a week. Hope you found this interesting. We were able to rehabilitate this eye through significant hardship, but we're hoping on a very happy ending on this very pleasant young lady. John Canalopoulos signing out. And I just want to add that there's nothing more important than following our cross-linking patients, even without a surface ablation or with a surface ablation, because the treatment we perform in the postoperative period is as important as the intervention. Again, thanks very much for your attention.